After nearly 25 years working with patients who need dental implants, I can tell you that the same 8 questions come up every single time, and almost none of them get answered properly in a standard consultation. I've treated thousands of patients across complex implant cases, full arch reconstructions, and even patients who've been told elsewhere that implants were not possible for them. These are the questions that I hear in my clinic every single week. Now, some of what I'm about to tell you will probably match what you've already read online, and some of it may not. The difference is I'm telling you what I actually say to real patients and not just what sounds good on a website. I'm going to go through all 8 questions, give you a straight, honest answer to each one, and make sure you walk away knowing exactly what to expect before you ever sit on a consultation chair. Point 1. Do implants hurt? Patients come in braced for pain because they hear the word surgery attached to implants, and surgery has always meant pain in their experience. Now, what I actually see across cases ranging from single implants to full mouth reconstructions is that patients are usually surprised. The procedure itself is done under local anesthetic, so you feel a little bit of pressure, you may feel some movement, but you certainly don't feel any pain. The discomfort most people describe afterwards is more like a dull ache rather than anything sharp. Patients describe it as far less than what they expected. Now, this question matters because fear of pain is the number one reason most people delay treatment by years. And every year that passes with failing teeth is a year of bone loss, of more complex treatment ahead, and of living with a problem you actually came in to solve. The fear of implant pain keeps more people in pain than the implants would ever cause. Where this gets more personal is when someone's had a history of painful dental experiences, because that history changes what they need before they can feel calm in the chair. If pain or the fear of pain is your main barrier, sedation dentistry exists specifically for you. It's not the last resort for extreme cases. It's a straightforward option that means even patients who've avoided the dentist for years can easily go through implant treatment in a calm, controlled way. Ask about it directly in any consultation. Point 2. Will I be without teeth during treatment? Nobody wants to walk around without teeth, and most patients are too worried about how this question sounds to ask it directly. I see this concern in almost every full arch case I take on. Patients will ask me every other question first and eventually get to this one last, as if it's a shallow thing to care about. It's not shallow, it's one of the most important practical questions you can ask. For the vast majority of cases in my clinic, patients don't go without teeth. For full arch cases, the plan almost always includes temporary fixed teeth placed shortly after surgery, so patients leave with something in. For single implants or smaller cases, the approach depends on the position and what's visible. This matters clinically as well as socially. Temporary teeth during healing, they're not just cosmetic. They help protect the implant site, they maintain your bite, and they mean you're not adjusting your entire life around a gap in your mouth for months. Asking whether you'll be without teeth is not vanity, it's a completely reasonable clinical question. The answer depends on the type of case and what your specific timeline looks like, which is why this is a question that should be addressed inside your consultation plan and not just as an afterthought. If this hasn't been addressed in any consultation you've had, ask for it directly. What do I have in my mouth between surgery and the final result is a completely fair question, and the answers should be clear and specific before you agree to anything. Point 3. Am I too old for implants? I see this assumption constantly. Patients in their 60s, 70s, and yes, their 80s walk in assuming age is a limiting factor. It's not. Age is not what I'm assessing when I decide whether someone's suitable for implants. Health is. What I'm actually looking at is bone quality, gum health, and overall medical suitability. I've placed implants in patients well into their 80s who went on to eat what they wanted and smile without thinking about it for years afterwards. The question's not whether you're too old, the question's whether your health profile supports the treatment. Now, that's a different question entirely. This matters because the patient who dismisses themselves based on age almost always would have been suitable. They just never found out because they stopped before asking. Age is not a barrier. Assuming age is a barrier is the barrier. Whether you're specifically suitable is something only a proper clinical assessment can confirm. But assuming the answer is no before the assessment even happens is the one thing guaranteed to get that outcome wrong. If age has been your reason for not pursuing this, book a consultation and ask one specific question. Am I medically suitable for implants? Let the answer come from a clinical assessment, not a number on a birthday card. Point 4. What if I don't have enough bone? This is a question that follows patients who've been told that implants are not possible for them, and they've been living with that verdict for years. Out of every question on this list, this is the one where I see the biggest gap between what patients have been told and what's actually true. Patients come to me having been told they don't have enough bone for implants without ever having a 3D scan. A standard X-ray doesn't give you that information. You need to make that call. A cone beam 3D scan does. And once I have that scan, the picture is almost always different from what the patient was expecting. Bone grafting, sinus lifts, and modern implant planning techniques have changed what is possible significantly over the last decade. Cases I couldn't have treated reliably 15 years ago, I can plan with absolute precision now. This matters because not enough bone has become a default thing to say in consultations that don't have the technology or the experience to solve complex cases. It's sometimes true. However, very often it's not. You don't have enough bone usually means the dentist in front of you doesn't have the tools to work with what you have. Whether bone loss is genuinely a barrier, your specific case requires a proper 3D scan and an assessment from someone experienced in complex cases, not a verdict based on standard X-ray. If you've been told that bone loss rules you out, get a second opinion from a specialist who places complex cases routinely, and specifically ask for a 3D scan as part of that assessment and find out what your options actually are before you accept that verdict. If these are the kind of questions you've been carrying around without straight answers, hit subscribe. Every week I put out a video designed to give you the full picture before you make a significant decision about your teeth. Point 5. How long does the whole thing take? Patients want to know how long this is going to run for in their life, and they almost never get a number they can actually plan around. The answer is it depends on what we find at the assessment, but I can give you a clear timeline once I know what we're dealing with and what we're working with. For a single implant in a healthy site, from placement to final crown, you're typically looking at around about 3 months. For a full arch case, the timeline is slightly longer and it has a few stages. What I see constantly is that patients who understand the stages up front find the whole process far less stressful than patients who were given a vague answer and spent months not knowing what was coming next. The timeline is manageable. The uncertainty is the part that wears people down. Knowing the timeline matters because patients make decisions about when to start based on life events, work schedules, and what they think they can handle. An honest timeline lets you plan. A vague answer leaves you paralyzed. The wait time is not the hard part. Knowing what you are waiting for is. The specific timeline for your case depends on your bone, your gum health, and how many teeth are involved, which is why the first appointment is about mapping out what you are working with, not quoting a number before seeing the scan. Walk into any consultation and ask for the treatment to be broken into stages with an honest estimate for for each one. You should leave knowing what happens first, what comes next, and what the finish line looks like. If that's not part of the conversation, ask for it to be. Point 6. How much does it cost? This question sits in the room through the whole consultation and then gets asked quietly at the end. Usually with an apology. I see this every week, and the answer I give is never a single number, because the cost of implant treatment depends on what the assessment reveals, how many teeth are involved, and what the site needs. What I find myself saying more often than anything else in these conversations is this: the relevant comparison is not the cost of implants against nothing, it's the cost of implants against the total cost of everything that's already been spent on treatments that didn't last, plus the cost of everything still to come if that cycle continues. I've had patients sit across me having spent 5 figures over a decade on crowns, root canals, and repairs on the same teeth, and they're still in the chair. The implant solution they need now would have cost far less than the repairs that they've already paid for, and they would have been sorted years ago. The cost question matters because it's almost always being answered against the wrong comparison. Patients compare implants to the price of a crown. They should be comparing implants to the lifetime cost of continuing without a long-term plan. The most expensive dental decision most people make is not the implant, it's the years of repairs they had before they finally stopped. What that comparison looks like in your specific situation depends on what your current dental history has cost and where it's heading, and that conversation is worth having directly in your consultation. Now, before you react to an implant cost, write down every significant dental treatment you've had in the last 10 years and roughly what each one cost. Then look at that number and ask yourself honestly whether that current plan is going to stop that list from growing. If the answer is no, the implant number looks very different. Point 7. How do full arch implants actually work? Patients hear full arch implants and nod, but most of them have never had anyone explain what is actually happening. I see this gap in almost every new full arch patient I work with. They come in knowing they want fixed teeth, knowing implants are involved, and not knowing much beyond that. The basics are pretty straightforward. For a full arch, we typically use 4 to 6 implants per jaw. Those implants go into the bone and act as the root system. A fixed bridge attaches to those implants, giving you a full set of teeth that you don't have to remove. The digital planning that happens before the surgery is where the precision and magic comes in. We use 3D scans and a digital design to plan the exact position of each implant before we place a single one. That planning is what allows for predictable outcomes and in many cases allow patients to leave with temporary fixed teeth on the same day as the surgery. Understanding how it works matters because patients who understand the process feel in control. Patients who don't understand it feel like things are just happening to them. That difference shows up in how they recover, how they communicate during treatment, and how satisfied they are with the result. Full arch implants aren't that complicated once someone explains to them properly. They're only mysterious because most consultations never do. Whether a full arch approach is right for your specific situation depends on how many teeth are involved and what the bone and gum assessment shows, which is what the consultation is designed to map out. Ask in any consultation for a visual explanation of the full arch process, ideally using your own scan rather than a generic diagram. You should be able to see where those implants go, what they are supporting, and what the finished result is designed to look like before you agree to anything. Point 8. What should I do if I'm terrified of the dentist? This is the question patients ask last because they assume the answer is just try to relax, and they already know that doesn't work for them. Dental anxiety is not a personality quirk, it's a clinical reality that I see in a significant number of patients I work with, especially in the implant population. Many of the people who need the most complex treatment are the people who've been avoiding the dentist the longest because of fear. And that avoidance is part of what got their teeth into the state they're in. We offer IV sedation specifically because I kept seeing patients who had the clinical need and the genuine desire for treatment, but just could not get through an appointment. With IV sedation, those same patients go through procedures calmly, recover without distress, and often tell me afterwards that it was nothing like they expected. I've had patients tell me they've not been to a dentist in 10 or 15 years because of fear, and they went through a full arch dental procedure under sedation without any issues. This matters because anxiety is one of the main reasons people with failing teeth never get the treatment they need or even want. Every year they wait, the treatment they eventually need becomes more involved. Addressing the anxiety is not a luxury, it's part of the clinical plan. Dental fear is not a reason to avoid treatment, it's a reason to ask specifically for the kind of treatment that accounts for it. Whether sedation is appropriate for your case is something to discuss specifically in your consultation. It's not something to dismiss as unnecessary, even before you've asked. Walk into your next consultation and say it directly. I've got significant dental anxiety and I want to understand what sedation options are available for me. That sentence alone changes the whole conversation. You're not asking for special treatment, you're asking for the right treatment for your situation. What I see across thousands of patients is that the fear, the uncertainty, and the delay almost always come from the same place. Nobody sat down and gave them the straight answers early enough. You have those answers now. If you're thinking about booking a consultation, watch this video next. It covers the one mistake that happens before the surgery even starts, and it's the thing most patients never think to check.